Yeah, this is Eric with the Disability Guerrillas, and I'm very excited to have two guests with me today, Dr. Laura Boright and Dr. Chris Wilson. And I've worked with them in the past, so this is truly an honor to have these two guys here with us today. We'll go ahead and actually, Lori, can you introduce yourself, and then we'll have Chris introduce himself afterwards as well.
Absolutely, Eric. Thanks so much for having us. And it is truly an honor to be here and also to have collaborated with you for so many years on multiple projects. So thanks for inviting me. I am an assistant professor at Oakland University and the new director of clinical education at Oakland University. So that's been an exciting transition for me. Chris knows all about it because I inherited the position from him. He will explain his new role, I'm sure, as well. So I am full-time faculty. I've been there for about 6 years on a full-time capacity, but I think over 10. I don't know. I'm losing count because, again, Chris looped me in years and years ago. And I say on my good days, I thank him. On my bad days, I blame him. But it has been a
Sure.
wonderful journey in academics and, kind of what drove me into academics. And I know that's precisely why we're here tonight. Some cancer diagnoses in my family, not personal, but certainly loved ones. And I returned to academics to really help sort of bridge the gap in research and also just personal knowledge in my own life and certainly helping to enhance the lives of some of my loved ones. So that's been really, really exciting. Along that journey, I've had many opportunities for service. So I'm currently the co-chair of APTA Michigan's Oncology Rehabilitation Special Interest Group. I also chair the APTA Oncology Hospice and Palliative Care SIG. And very recently, within the last couple of years, helped to establish Oncology Rehabilitation in Practice, which is our new clinically focused journal sponsored by APT Oncology. So that's been a really exciting endeavor as well. So thanks again for having me. I'm grateful to be here, Eric.
Yeah, now, Chris, can you introduce yourself?
Yeah, happy to. Eric, thank you so much. And first of all, I want to echo kind of Lori's sentiments. It's been an honor to continue to work with you. You truly are a visionary, really kind of advocating for patients, for the profession, for disability issues. And I think it's really an honor to be here and support you in that. And I think it's such an important thing. And especially as physical therapists like Lori and I are, we see it, we want to help with it, but we aren't living it. And, the voice of the person who is having their disability as part of their identity is really, really important to get that voice and empower it. So thank you for your work with that. So I am Chris Wilson. I am the Associate Dean of the School of Health Sciences at Oakland University. As up until about 5 minutes ago, I was the Director of Clinical Education, but Lori Bowright got tagged in your it. So Lori is it now, which is a really, really great job. Both jobs, my new Associate Dean role is wonderful, but also being Director of Clinical Education, because you get to help students embrace their future and kind of embrace kind of what they went into the profession for, was to help people at the moment that they need the help the most and with what they determine that they need help with the most. And to be able to kind of help them work through, because, especially as DCE, Lori will probably say, see that there's a lot of students that find that they think that they know what a person needs, and then maybe that's different than what the person actually feels that they need or what they actually need. And there's a little bit of cognitive dissonance associated with that. So I think that's something that in that DCE role, I really enjoyed helping students kind of navigate some of those areas to help them really be a better practitioner and a better provider. So I'm still practicing clinically. I am very, very part-time at Corewell Health in Troy, which used to be Beaumont Hospital in Troy, Michigan. Um, and I've been there. In next June, it'll be 30 years. So I'm kind of working there as much as I can. And then I also, like Lori, do a lot of service activities. Right now, for the American Physical Therapy Association, I'm president of the Oncology Academy. Um, but I also serve on several other organizations such as Commission on Cancer, American College for Sports Medicine, and then with Lori and another colleague, Ann Henshaw, we're working on the American Palliative Rehab Alliance because just because someone is eventually going to pass away from some type of illness does not mean that they should not have access to high quality rehabilitation professionals. It's human right, and that's something that we truly believe, and that's why we kind of created that organization. So enough about me. Let's get on with it.
Okay. All right. Well, actually, Lori, I'm gonna start with you here. I'll just start off swinging. What is the role of physical therapy in oncology?
Yeah, Lori,
So
what is it?
this is a great question to tee off with, Eric. Thank you for asking that question. This is kind of an easy one, but for us, in the domain, it's very easy, but it's very important to be able to articulate what we do. Even we have professionals within our physical therapy profession that sometimes don't understand it, and certainly there is a need to educate our colleagues in other domains of healthcare. So, a physical therapist in the oncology domain is really tasked with working in multiple areas of prevention. Certainly, I would be remiss if we didn't advocate for primordial, which is prevention at the community level, primary prevention, which is at the individual level, prevention of cancer itself. Secondary and tertiary prevention are becoming a little bit more mainstream, but certainly it's still not standard of practice. So secondary prevention is another term for that is prehabilitation, which is very common in our orthopedic domain, where someone might have an exercise prescription prior to a total knee replacement or a spine surgery, for example. It is important for people who are living with and beyond cancer and about to undergo some sort of intervention for their cancer to be fortified as well, physically, emotionally, spiritually, fortify their whole self to withstand the rigors of a cancer treatment. And then tertiary really is dealing with the adverse effects that are resultant of some sort of cancer modality for treatment. And so cancer-related fatigue, chemotherapy-induced peripheral neuropathy, a couple of examples, cardiotoxicity. We are tasked with assessing and intervening with our skills and knowledge to help individuals recover their strength and independence from those subsequent insults, for lack of a better word. We call them adverse effects or insults from cancer.
Now, you mentioned prehab before. Now, what exactly, if I'm just a new patient, can you describe what prehab is and what kind of exercises do you do in prehab?
So prehabilitation really is a growing area, and some of my early research was focused on prehabilitation, specifically in the head and neck cancer domain. But prehabilitation really is a combination of things, not only exercise, but nutrition, psychological counseling, spiritual counseling, to really address the needs of the entire individual. Again, to help fortify every aspect of their being to withstand the rigors of the oncoming cancer treatment. So the exercises really should be tailored to the individual needs.
So, actually, Lori, can I ask you, what types of exercises typically would you do? Aerobic or muscle strengthening, or can you give
Yep.
everyone an example?
Any and all of that. So an aerobic exercise program might consist of a walking program. So if an individual, let's say they can I'll just throw out a distance about 1,000 feet in 6 minutes. We would want to make sure that we are addressing, the impairment, and have them try to add about 5 minutes a day until they're walking, 20 to 30 minutes. Education is another huge piece that I haven't mentioned really quickly. I'll get back to other exercises, but we need to educate our patients that they're exercising in a safe zone, and an appropriate zone. We want them to get, to that moderate intensity level. So teaching them how to use the Borg scale for gauging their exertion level, right? Again, to get them into that moderate zone, and also potentially even monitoring their vital statistics. I'm reading a lot now about the wearable technology and how useful it is. There's more and more research coming out all the time about how wearable technology is helping to motivate patients, gives them data that they can, use again if we give them a target heart rate, they can use their wearable technology to help them get into that zone of where that target heart rate is. So that would be the aerobic side of things. And then certainly resistance exercises as, we would evaluate a patient, screen or evaluate a patient. We identify potentially an area of weakness. Again, we'll go with the individual maybe who has breast cancer, who has some upper body weakness, some core weakness. We would definitely want to address that with prescribed exercise. It's a little bit hard to answer your question, like what exactly types of exercise, but I think what you're helping me to articulate is that it should span aerobic exercise, resistance exercise, certainly stretching and flexibility exercises as well.
Yep, I love that. And Lori, just to add to that too, I think, I try to equate this a couple of ways for patients, because one, I think it's really kind of tough because you're asking them to do something extra when they are oftentimes at their emotional max. Like they've just gotten like the news of their life, and then some physical therapist coming in saying, you should be exercising more. You should be doing X, Y, and Z. And I mean, there's emerging evidence that's kind of starting to say that people who do prehab programs, they bounce back faster. They get back to work faster. Their lab values, if they need chemotherapy, drop less and return to normal faster. Those are the type of things that I really try and use the prehab concept to empower the patient and say, this is something that is within your control that you can tangibly do to improve your cancer outcomes and improve your life while you're doing it. And finally, I'm a big analogy guy. If you talk to me more than 5 minutes, I like to talk in analogies. And I kind of say it's when you know that there's a storm coming and you left all your windows open, you're going to try and hopefully get home and close all your windows and, put away the furniture because a big storm is coming. And that's kind of what a little bit of prehab is, to kind of, anticipate some of those things. And I think that storm analogy is good, but I also know that oncologists and oncologic surgeons and radiation oncologists, they work extremely hard to make sure that storm is very, very minimal, that it's a light drizzle. But sometimes, even in a drizzle, I would still like to have my windows closed sometimes. So, it's kind of preparing for the worst, but hoping for the best and giving the person tools to do that.
Yeah. I just wanted to ask you, Chris, like, what do you think is the prevalence of disability in cancer patients?
I think it's pretty high. I don't have any numbers in front of me. But that's actually something that I'm working on right now with some colleagues at Harvard and other institutions to really actually figure out what type of prehabilitation programs we can do to limit the impact on work-related disability. I talked to my first year physical therapy students when I taught patient management class, which Lori teaches now. I tell them probably very crude analogy is that we in a fable, two people go walk into a forest and they're both going to chop down some firewood. They're going to get their axes and chop down some trees to get some firewood. One of them is a singer, the other one is a violinist, and by matter of crazy happenstance, because this is a fable, they both cut off both of their hands. Now the singer is not necessarily disabled, at least not when it comes to their work or occupation. The piano player or the violinist is, because their hands were their occupation or what they chose to do. So again, it's very, very crude, probably not necessarily super sensitive, but it connects with the students because they can't always say, someone's physical limitation is always tied to a disability, that they are sometimes two separate things. So from a little bit of shock value and maybe a little bit of, uncomfortable, analogies, I think it really kind of lends some insight into the students' minds, because they think, oh, someone has this issue, that means that they're not able to do X, Y, and Z, or they're disabled. No, it really depends on what you can do and what you can do differently. With a lot of assistive technology, maybe even that violinist or piano player can use adaptive technology to still play the piano or play the violin. So hopefully it opens up their minds to realize that just because someone has a certain physical limitation, it doesn't necessarily always equate to a physical limitation or disability. And there's a lot of contextual factors with it.
One of the big things for me as a survivor is fatigue. Like I never realized how debilitating that really is, and like uh, that was just a huge adjustment for me because yeah, I didn't technically have cancer. I had a benign brain tumor, but yeah, the fatigue just across the board. All the survivors I talked to, they say that's probably one of the biggest things that they weren't prepared for.
100%.
It's
Yeah.
interesting that you mentioned that specifically, Eric, because cancer-related fatigue really is the most highly reported adverse effect dissatisfier among those who are living with and beyond a cancer diagnosis. And it has the potential to be debilitating in the moment and persist for, years to come. So the really positive thing that I like to focus on is there is a lot of evidence now and growing and emerging new evidence related to mitigating that adverse effect with resistance and aerobic exercise prescription. So again, another hugely important role we have to play just with that one adverse effect alone.
Yeah.
Yeah. And I
Yeah,
think probably,
again, like exercise is probably the best way to address that, and physical activity.
yeah.
It,
And I
it
think
really
probably
is.
the big thing too is that is from a healthcare provider standpoint, screening people for it and using valid, reliable measures to screen and quantify for it. Because again, maybe you, Eric, experienced this, but I certainly know many patients have. Is that there are ebbs and flows to fatigue, and just because you ask someone something at one point in time, maybe they're having a really good day and their fatigue is quite low, but we need to keep checking in on that, because sometimes maybe patients or individuals are having an exacerbation of fatigue, or sometimes there's even a mental or emotional component to fatigue. I mean, sometimes we all have gotten home from a busy, stressful day, and you really haven't done anything but sit on your backside and work on your keyboard, and you're fatigued. It wasn't physically exhausting, but you were dealing with things psychologically and emotionally. And I think we can't forget about the emotional and psychological components to that, because they really are all connected, even to the concept of, with some people who have gone through cancer and are in remission, there's always that fear of recurrence, and it's kind of in the background, and that is it. For some people that I've talked to, it's exhausting because you're constantly thinking about some of those things. So that's where that education comes in, to let people know that fatigue is not necessarily something, this is not necessarily your new normal. There are things that healthcare providers can help you with, but sometimes patients also need to advocate for themselves, because yes, if you go to Lori and I, we're probably going to nag you about fatigue, but if you go to a different provider, or maybe someone not necessarily is in tune to that, maybe they're not necessarily going to ask about it. So that self advocacy is really important. I think that's something that is still tough for
Yeah.
people to do in the healthcare, when they're dealing with the healthcare system.
Now, Lori, can I ask you, like, so how do you address fatigue in the clinic? Like, I mean, do you just work on exercise, or what exactly? What kind of exercises?
Sure, exactly. So I think that taking a step back, the first thing is assessing the patient.
Okay.
And through, as Chris had mentioned, some objective and reliable measures. I really do like, pardon me, allergies in Michigan. The 6-minute walk test or the proxy 2-minute walk test. Certainly, there are other really easy to implement assessments for the a new step protocol. The University of Northern Colorado Cancer Rehab Institute has a modified treadmill protocol, again, that is much more easily, is it an easy test? No, but it's more easily tolerated for those who are living with and beyond cancer. So getting a baseline measurement, not only of their physical capability, but also how their body is tolerating that. Sometimes patients will underreport their symptoms to you, including fatigue, because they are just happy to be in front of you and working with a clinician who has some knowledge and expertise that can help improve their quality of life. So again, patient education, we cannot underscore the importance of that, and helping them, again, to understand what exercising in a moderate range is. And then once we have their baseline, not only vital statistics, but performance measures, strength, endurance, those kinds of things, we do the due diligence of a individualized exercise prescription. So if that involves again, walking program, or potentially maybe like a elliptical, whatever, again, that they can tolerate, helping to get them into that moderate range. We want to address the strengthening aspects, as well as a little bit of flexibility, all rolled into a 150 minutes moderate intensity exercise program.
Now, I've been out of the clinic for quite a while, but how do you maintain, or how do you monitor and make sure that the patients are actually doing their exercises? I mean, what's the best way to do that to ensure that?
Love that question.
Yeah,
You want to
that's
take
a
it,
really
Chris?
good question.
I think what we do for traditional physical therapy doesn't necessarily always match what we need to do for people who are living with or beyond a cancer diagnosis or another chronic disease. So people that have long-term conditions that maybe are stable, maybe are potentially getting a little bit worse. And I'm a geriatric specialist, so none of us are getting any younger. So we all are going to kind of start having more aches and pains. After about the age of 25, stuff just hurts when you wake up and you don't know why. That's just kind of what happens. And we need, I think, to change from that episodic model of 3 times a week for 4 weeks, and I hope I never see you again, is periodic checkups. I also do some reviewing for an insurance company, and whenever I see a person trying to wean down a person, or again, maybe you're doing 3 times a week for a couple of weeks, and then 2 times a week for a couple of weeks, and then once a month for 3 or 4 months, I get it. I mean, you can take those same 12 visits and spread it out over 6 months. And then you can kind of help with that long-term behavior change. Because, it's just like if someone is quitting smoking, or quitting substance abuse, or quitting some other habit that they want to change, it's not going to be like one health professional tells you once. It truly is a behavior change to find out where they're at. And they need that ongoing support and guidance.
I think that's really interesting, Chris, because again, just being on the other side, on the patient side of things, I think like if the patient side is more mobilized, we'll see more change. Instead of having a doctor or a physical therapist or whatever telling you to do something, but if it's one of your peers, I think that holds a lot more. Not a lot more, but it holds a lot of strength to the argument. So
Yeah.
I'd just like to kind of dovetail on my soapbox, and I've mentioned it a couple of times already, is patient education. I really do wholeheartedly believe that knowledge is power. When we can empower our patients with knowledge of all the things that Chris just mentioned, as well as the benefits of exercise for their unique condition, and they return to their physician with ideally improved status, and Eric, I even think you mentioned this a little bit, that it's a very powerful, convincing tactic to win over others in the medical community. And I never want to discount the benefits that other providers are providing our patients, but the medical community, they really are in the life-saving domain, and we are in the life-enhancing domain, which really is just as important, especially when we're talking about the oncology domain and the chronic illness domain. So empowering our patients with the knowledge of the benefits of the services that we can provide today, tomorrow, long term for their quality of life throughout their survivorship trajectory.
Okay, I'm gonna switch gears a little bit, but Chris, I wanted to ask you. So, like, what exactly are you doing now? I know you kind of got a lot of you've got a lot of hats to wear, but I was just curious. Like,
Yeah, so
Me too.
yeah, me too, actually. No, I'm in the over the summer I transitioned to be an associate dean of the School of Health Sciences, which is really great. It wasn't one of those things that was in my life goal or my life trajectory, but I'm also a big believer in sometimes opportunity doesn't always knock twice. As part of the American Physical Therapy Association too. So we're doing a ton of really, really great stuff. We just published entry level guidelines. So really kind of establishing what every physical therapist, whether they go into oncology care or not, needs to know about providing care to someone with cancer or a history of cancer or even at risk of cancer. Because I don't know about you, Eric, but they didn't really talk a lot about cancer when I was going through physical therapy school. And it was a problem because that is one of the big things that I think is really limiting our profession from being all we can be and being able to provide the services to our patients is our own lack of confidence. Lori and I, and Eric, probably one of your mentors as well, is Deb Doherty, and she says that we have the skills. I mean, unless you're like a lymphedema therapist, yeah, maybe they don't teach you that in entry level, but physical therapy for someone with cancer is not that much different than someone with an orthopedic or neurologic condition or a cardiovascular and pulmonary condition. The interventions are the same. I mean, all the tests that Lori talked about and all the interventions, that's stuff we already know and do. It's the cancer terminology and all the scary words that come with it that kind of give us a little bit of imposter syndrome.
Yeah, I think we're doing a disservice. I've been really fortunate to collaborate with Deb Doherty on a modular curriculum that she and I have developed and evolved over many, many years. We've delivered it to every single DPT program in the state of Michigan as of 2024. So there are newer programs that are emerging, but at that point we had delivered it to every program. And we've even worked with international colleagues now to deliver in South Africa and areas of Europe, including Bosnia. And that's the exact messaging that Chris had mentioned is that, the bringing down that level of fear. You have the tools and the knowledge. You just need to apply it look at it through a little different lens and apply it with a little extra care. Be very, very cognizant of the physiologic response to your assessments and interventions. But, and this is the big giant punchline, it's not if, it's when you will encounter an individual in your practice who has a cancer diagnosis currently or in their history. Because of the prevalence in our society, it's not if, it is when. So being comfortable to, use your entry level skills and refer, if the things that you evaluate are, scope, and ability to manage, it is your inherent responsibility to refer to an individual who can help manage those things.
It's a little bit of that professional humility to, I think
exactly.
there's kind of two parts of it is that professional humility that we don't have to know everything, but we do have to know who knows that stuff. And I think that's an important part of our role is kind of giving them maybe a Band-Aid or a temporary solution that until they can kind of get to a pelvic floor specialist or a lymphedema specialist or someone to really work with their ataxia or movement disorders.
Yep, asking the right questions, screening for the things that can be addressed by another individual, and then offering any skills within your purview until they can see an individual with that specialty skill set, I think is the baseline responsibility we have as professionals.
Yep.
Yeah. So actually, Lori, I wanted to ask you, like, you've got a lot of stuff going on right now. Like, what exactly are you doing now? I mean, you mentioned very briefly earlier, but
Yeah,
Like
yeah.
what's going on?
Absolutely. My life is multi-dimensional. There's a lot going on. You are not kidding, but it's wonderful. I am doing two things, as my mentor says, embracing the chaos and enjoying the journey. I
Yeah.
truly, truly am.
Love it.
So my full-time day job, work life, which extends many days well into the evening, so I shouldn't even call it a day job. At the university, at Oakland University, where I am fortunate to work. In my new role as director of clinical education, I'm really tasked with managing the all aspects of our clinical education program. I also coordinate our graduate certificate program in oncology rehabilitation, which is a post-professional program entirely online with a global student body. We have 4 courses delivered over 2 years to help prepare professionals, and it really is designed for the working professional, the post-professional who has a degree either in physical therapy, occupational therapy, exercise science, to again assess and manage the manifold and complexities of the individual who is living with and beyond cancer. I do also practice clinically at Henry Ford, which is a health system here in Metro Detroit, at our Macomb Hospital in Clinton Township. Again, as Chris mentioned, very part-time, but it is still a mainstay. It's why I became a physical therapist. I really do value working with patients on a regular basis. I need my hands on my older adults, helping them to thrive in their later years. That really is my my area of expertise as well, geriatrics and the medically complex.
Well, I'm gonna transition here a little bit. Like I know, Laura, you've seen some of the old videos to get to know you as an individual.
Oh, geez,
I
you don't
kind of
want
want to humanize the healthcare professionals, so our patients, feel comfortable approaching us. And then,
Absolutely.
yeah, and also it's just fun putting you on the spot. So,
that.
I'm gonna go ahead.
Love it. Bring it on.
I'll bring it on. Okay. Well, actually, Lori, since you've seen this before, I'm gonna start with this question for you. We'll go with you, and then you can go ahead and answer. What is your personal theme song?
I will probably say, I don't know who sings it, but I'm a survivor, and it really resonates with me, but it's a surviving, and sometimes even beyond that, ideally it's thriving, right? And I feel the same and work hard towards those ends so that I can bring that person to all aspects of my life. And I think about oncology patients and their survivorship, right? They're in a similar struggle, if not, a little more expedient in terms of, the circumstances potentially are a little more dire. So helping them to thrive through their survivorship.
Okay, now, Chris, what's your theme song?
Ooh, no, that's a good question. I'm gonna go with an actual theme song, and it's the Star Wars theme. Star Wars. So yeah, because I think there is something, heroic and aspirational. I'm an eternal optimist. Till the day I die, I always will believe the best in people and believe that we can save the world together. And I think that movie really resonates with me. Plus, the first one came out the same year I was born. Yes, I'm that old, everybody. And that was actually to the point where I didn't get very many decisions when I got married, but the one decision I got to get was like when we walked into the hall, what was the song? And that was the song. It was literally the Star Wars theme song. And I kind of want us to all to be kind of Luke Skywalker, or that person that's kind of picked out of the farm fields to kind of get thrown into a situation, thrive, and help make the galaxy a better place. I don't want to just save the world. I want us to save the galaxy. So no pressure.
Actually, this is kind of off topic, but a lot of the male physical therapists that I've talked to, the Star Wars theme song. It's like a common theme.
It's a jam. I mean, that'll give you goosebumps.
Yeah, I'm guilty, but yeah.
Yeah.
And I'm gonna just add, because I had to Google it. It's Destiny's Child, so I'm a little bit older too. I'm going mid-90s with it.
Right. next question here. All right, and Lori, we'll start with you again. Who is your hero?
Wow.
You don't
It's
have to
hard
say me, Lori.
Chris.
I'm just kidding.
Well, I don't know. I mean, for me, it's less about a specific person and more about an embodiment. And maybe it sounds a little bit corny, but every cancer survivor is literally my hero. And for me, it's touched my life personally, in terms of family members. And those experiences really were the impetus for me to be exactly where I am right now. So, I really do feel like my mom, my dad, their subsequent cancer diagnoses opened this wellspring of opportunity to provide, and work towards providing a better quality of life for every cancer survivor that I can touch. And I feel like through teaching, I touch more than I can just by myself, right? If I'm teaching others to do this work. So I'm a prolific answerer, but I will say every cancer survivor is my hero.
I think that's a good answer, Lori. I would probably say personal mentors, I think, are my hero. I have a few. I think that's kind of one of the big things is that someone that takes on the mentorship role to really recognize your undeveloped talents and skills and turn them into actual talents and skills. I have several. We've already talked about one, Deb Doherty. Raina Colombo is like my second mother. She kind of helped nudge me into leadership roles, maybe when I wasn't ready for it and kind of when I didn't need it yet. But she took me under her wing. And Chris Thompson at Oakland University is another one. And then the last one, and I'll tell you something that just never forgot. Another friend and colleague, her name is Jakubiak Kofasek from Michigan. And she told me one thing that I will never forget. And literally, this is my motto. So if this is your next question, is what's your motto? Here it comes, Eric. Is that my motto really is, if you don't embarrass yourself once in a while, you're not trying hard enough. So don't be afraid to embarrass yourself, especially when you're doing it for a noble cause like our parents or our patients and people with disabilities. If you're not embarrassing yourself, you're not. And so I take that to the nth degree. I embarrass myself all the time, but I say that it's okay because I'm kind of trying. So that's my answer.
Okay. All right, we've got to throw you guys a curveball here. This is going way back. Mathematics. What is an obtuse scaling triangle?
I know obtuse means that it has a bigger than 90-degree angle.
I agree, 90 degree.
Okay.
What's a scalene triangle?
Yeah.
Isn't a scalene where two sides are the same? This is why I became a physical. Was I close or no? Oh no.
Yeah, it's close. Three sides are different angles or different. Yeah, different.
Oh, okay.
It's more about the length.
Okay.
So this is why I went into physical therapy, so I didn't have to do math. I need to know 3 sets of 10 equals 30. That's all I know.
Yeah.
So,
and 5 episodes of 30-minute bouts of exercise is 150 minutes.
That's true. All right, I can handle that
There
too.
you go. Okay. All right, next question here.
Woo! I don't discriminate. I am an equal opportunity caffeine consumer. I can't pick one because it just depends.
Okay.
I guess I will say coffee when I'm healthy, tea when I'm a little unwell.
Agreed.
Okay.
Go ahead, Chris. Sorry if I
Yep,
stole your
I'm the
thunder.
same way. Yeah, like if I'm drinking tea, it's because I have a sore throat and I don't feel good and I want some comfort. But coffee will keep me running probably more than I want. Interestingly, here's a little anecdote: was when I was getting older, the blood pressure was creeping up a little bit, so I decided to have decaf coffee. Honestly, I didn't really feel that much different. I thought I would be like this blob of no energy, and I kind of felt no different. But it was kind of a pain to have to like ask for decaf and not drink coffee because it's decaf. So I'm glad it didn't really change my blood pressure or my energy. So I went back to regular coffee.
Noted.
Oh, for try that. Okay, so actually, we'll start with you, Chris. What's your favorite website?
Ooh, that's a great question. I think my favorite website is IGN, which is a video game and movie website. I'm a prolific video gamer. That's kind of like, if you're asking me for my like guilty pleasure, I would be playing Legend of Zelda or Super Mario or Assassin's Creed, just because that kind of, and even if I can't find the time because I am very busy, even just reading about things like that kind of help me, bring me pleasure. So I would say, yeah, that's kind of it keeps me, there's always video games that are coming out 6 months, 9 months down the road. It kind of helps keep me going a little bit. So
I'll go with LinkedIn.com if that's I don't even know if that's the website. It's more of like an app for me. But what I will tell you is, because it's similar to Chris's, I am not a gamer, but the LinkedIn games, I do them literally on the regular. It's like part of my morning routine now. I work with colleagues who really love the New York Times. I never really got into those. I mean, I love Wordle. I was doing that at the beginning. But the LinkedIn games are my jam. So there you go.
You know what I missed? Do you guys remember Minesweeper? Like on the old...
Oh, yeah, I love Minesweeper.
Yeah, vaguely. I don't know if I played it.
A lot of time on Minesweeper.
I play a lot of Minesweeper, a lot of solitaire on my computer.
Oh, yeah.
Okay, yeah.
All right. Right, and Lori, we'll start with you. Movies or TV shows?
Probably TV shows, and the kind you can binge, because that's my jam too.
Okay, like what?
Right now I'm watching Dead to Me. It's so smart, and actually we're watching it for the second time now. It's Christina Applegate, and I don't remember who else the other people are, but it is so smart and so well done. I just love it. Dead to Me.
I know. I'm kind of undecided. I do like both, and I think that's the nice thing about being in this day and age. Like, I like Marvel, so I have TV shows and movies, and I like Star Wars, so I got TV shows and movies. The one that I just finished watching was The West Wing. Remember that old TV show with Martin Sheen as the president and all that kind of stuff? Just finished watching that, and now I'm starting in on Scrubs because they're redoing the Scrubs TV show. So I got to back up on my Scrubs before the new season comes out.
Okay. Another question here. What is the capital of Maine?
Portland?
Augusta.
Nope. Augusta.
Woo!
Good job, Chris.
Yeah,
I would have said that.
You win $1 million.
Woo!
Okay, now this is I think you've seen some of the old videos here, but this is a very controversial question. Pineapple on pizza, yes or no?
Come on, Lori. Do me right.
I'm going with absolutely no.
Oh, Lori, we used to be friends, and now we're not friends.
I know, we can't be friends anymore. No, veggies. Load it with veggies, not fruit.
Oh, give me a Hawaiian pizza. My son is a big fan of Jet's Aloha barbecue pizza, so it's chicken, barbecue sauce, and pineapple. It's kind of amazing. So I'm a big pineapple on pizza guy.
Okay.
All for you.
Yep. All right, I'll take it. You can have your plain pizza with your pepperonis and your peppers and onions. Sounds so boring.
Okay.
I like eggplant and artichokes. If we're gonna go there,
All
what
Lori,
I like.
You're going to a different restaurant.
Eggplant? Wow.
Eggplant.
Never heard of that before. Okay, we've got 2 more questions here. If there was a movie biopic about your life, who would you cast as you?
Well, obviously George Clooney for me. There's no
Obviously.
Or Brad Pitt. No. Yeah. So someone that looks like they kind of have it all together. Because it's going to be fiction, right? It'll be fiction. So, yeah.
Okay.
This is hard, Eric. Oh my gosh. I don't know. This is so hard. I don't even know, like a movie actress.
I think it'd be like a Julia Roberts, Lori.
Yeah, well, see, she rose to the top, but I was like, is that going to age me too much? Like, I don't know. But she's back around. I think she does movies with George
See, that's
Clooney.
what I'm
Okay,
saying.
absolutely.
Yeah,
Right.
Julia Roberts,
We can do
hands
like
down.
Ocean's 14 together. They were both in Ocean's 11 or whatever.
There you go.
Yeah.
All right. Okay. I've got two more questions here. I want to ask you this one. Where's your favorite place to travel? We'll start with Lori this time.
So, as with most things, it kind of depends. If we're talking summer travel, I like to stay right here in the state of Michigan.
Okay.
It is so beautiful here up north. Literally, Kid Rock wrote a song about it. There is nothing like summertime in northern Michigan. So, the travel industry can contact me now. I'm a huge advocate for anywhere up north in Michigan. I'm a Southern California girl native, so I really do like the Southwest outside of the state of Michigan. I would say Arizona, Southern California. And then, if we're talking European travel, you can talk me into that too. So.
Okay. Chris?
I agree with Lori. Yeah, so Ludington State Park is my place. Lori's been there before too. Yes, is that my family's been going there since the 1930s, pretty much nonstop. It's on the west side of the state. If you're a Michigander, you got to hold up your hand and point to where it's at. So it's right there on Lake Michigan side. So we always go camping, and then my parents go, and my brother goes with his family, and my uncle goes and their family. So it's kind of a family reunion. We just spend the week at the sand dunes. My other favorite spot, my wife is she loves her Las Vegas. She's a Vegas gal, so we get some quality husband and wife hangout time in Las Vegas, and we get to go to the shows and gamble a little bit and drive out to the desert and do that kind of stuff. So those are some of my favorite places to go that we go to a lot.
Great. We got the last question here is any words of advice for survivors or for people with disabilities or just in general?
Or you want to go first, or you want me to?
Sure. I can take this. I think take this first. I think my personal motto and something that I hold dear is imparting good. I truly, truly believe that we are all created inherently to try our best and extend grace. So I really feel like, when you wake up in the morning, be grateful, first of all, that you're still here and you have the skills, knowledge, and talent to go out into the world and impart good. I really feel like that is, the thing I hold my hat on the most is just really trying to make a difference in people's lives, impart good, work hard, and reap the personal rewards that come from that. There's a lot of personal satisfaction that comes from knowing that you gave everything your all.
Yeah, and I think you already kind of heard one of my mottos was, if you're not trying hard enough, or you're not embarrassing yourself, or you're not trying hard enough. But I would probably say my other one is, don't take life so seriously. I think that's one of those things that I'm actually a little nervous about in my new role in Oakland. Is I'm not a super stuffy guy. I'm kind of casual, and I pour my heart out, and I put my heart on my sleeve. And sometimes that's not always the style in some of these upper leadership positions. But I think truly, if you speak from the heart and you try to impart a little bit of fun and humor and enjoyment, and I'm a big fan of whatever you're doing, try to find the fun in it. Try to enjoy life. None of us are here on this earth very long, so try to find some silver lining. Yes, there might be big gray clouds. There might be a lot of parts of our jobs or our lives that are tough, but try to find the right thing or pivot. I never got those people that went to a job every single day and I hated it. Like, I get it, like maybe you have to pay your bills and that's the only job you can have, but if you have options and you're going to a place that you don't enjoy, I never got that. Like, go somewhere where you're having fun, because life is short, and enjoy yourself, and don't be so darn serious. Enjoy life a little bit. So that's my piece of advice.
Yeah, good. Thank you so much, guys. That was the last question. So you're officially off the hot seat. So, yeah, and I'm looking forward to interviewing more PTs and healthcare professionals. So yeah, definitely spread the word, and yeah, and you guys have a good night.
Yeah,
Thanks, Eric.
thanks for everything you're
For
doing,
all you
Eric. We appreciate the time. Thanks for having us.